Hi, I'm Mary McQuilkin, adjunct faculty for the University of Alaska Fairbanks Center for One Health Research. This morning, I'm joined by Dr. Ros Singleton, who has a wealth of knowledge on maternal child health from her career as a pediatrician and physician researcher, most recently at the Alaska Native Tribal Health Consortium.
My name is Rosalyn Singleton. I'm a pediatrician. I worked my entire career with Indigenous health. I worked on the Navajo reservation, and then from 1988 through 2024, I worked for the Alaska Native Tribal Health Consortium in the Alaska area before that as a pediatrician and research physician.
Can you describe the disease burden of HIB in the pre-vaccine era?
Studies showed about 100 cases per 100,000 of Hib. About 50% of it was meningitis, an infection of the meninges around the dura, and of those who had meningitis, about 10% of infants died, 30% were left with severe cerebral palsy or deafness.
What was your experience as a pediatrician prior to HIB vaccine availability?
Before vaccine, I was working as a pediatrician on the Navajo reservation, and every month, at least, we had a baby with Hib meningitis. These were normal babies who got an infection that completely devastated them, even though we treated them with antibiotics. Meningitis has very nonspecific symptoms, fussiness and fever and lethargy in an infant. And most infant illnesses present with some fussiness and fever. So determining a child's status as having meningitis and then treating them quickly is very challenging, even in this day. At that time, nearly all of the infants and children who required residential care for severe vegetative disorder, that means they had very low brain function and needed to be tube fed and in a wheelchair, were from Hib meningitis. It affected every minute of our life in pediatrics. Among Alaska Native and American Indian children, especially in the Southwest, rates of Hib meningitis were at least 6 times higher than in the general population, especially in rural and remote regions. So that affected us dramatically in the work that I did.
Until very recently, Alaska was still using PEDVAX HIB, while every other state had been using the newer Vaxellus vaccine for many years. Can you explain why it was important to conduct research specifically on Alaska Native and Native American infants before it could be recommended that Vaxellus be used in Alaska?
Alaska Native, as well as American Indian children in the Southwest, not only had very high rates of Hib meningitis, but they also had disease at a much earlier age, towards the 4 to 9-month-old age. So a vaccine had to be very effective early in infancy, much more than in the rest of the population. When we started with vaccine in 1990, Alaska chose to use PEDVAX HIB because among the 3 vaccines that were available at the time, it was the only vaccine that got a robust immune response with the first dose and had any protection with the first dose at 2 months of age. The other vaccines, especially Hepatitis, which was the most common at that time, required 3 doses, so at least 6 months of age at the minimum to get full protection. We had a dramatic decrease, about 90% decrease or more in Hib disease initially. In 1995, there was a new combination vaccine that was available that was DTP, the diphtheria, tetanus, and pertussis vaccine, linked to Hib titer. The state changed to this combination to reduce the number of shots. It was the feeling at that time that vaccination with Hib vaccine would have reduced the number of children and family members who carried the bacteria in their nose and mouth. That's how you spread the infection. And that was true in the lower 48. In Georgia, there had been a study that showed carriage rate of only 0.1%. So the state went ahead and changed the vaccine. Within a few months, we started seeing increased cases among Alaska Native children, and we had an excess of 16 cases over the next year or two. And evaluation showed that most of those infants had had 1 or 2 doses of Hib titer and had breakthrough disease because there weren't adequate doses to protect them against Hib meningitis. In 2000, the state changed back to PEDVAX Hib, and at that time, we saw a dramatic decrease again in Hib disease and continued to use PEDVAX Hib. Vaxelis is a hexavalent vaccine, so it's a combination of several vaccines. It had been studied in many children, and studies had shown non-inferiority to PEDVAX Hib for Hib titers. Unfortunately, the drug companies did not evaluate the response after dose 1. That wasn't considered a priority for most populations, but it was a priority for us. Over the years, because of our first experience, the Advisory Committee on Immunization Practices and the American Academy of Pediatrics had made PEDVAX Hib a preferential vaccine for American Indian and Alaska Native infants. However, when Vaxelis came out, they declined to do that because we did not have that critical information about non-inferiority after dose 1.
How is interdisciplinary collaboration important for this research?
We had collaborated many years with the Johns Hopkins Center for Indigenous Health. In fact, their infectious disease director, Laura Hammett, had done her training in Alaska and worked directly with us at Arctic Investigations Program. So we joined forces, and Dr. Laura Hammett wrote an investigator-initiated proposal to Merck to conduct a non-inferiority trial to determine the non-inferiority of Vaxelis compared with PVAX Hib after dose 1, focused on dose 1.
How was the study design and research protocol developed for the HibVax study?
We chose the non-inferiority as this study had been conducted for dose 2 and 3. We chose a similar design, and it was a direct comparison between PVAX Hib alone and Vaxelis.
Why was randomization utilized in the study design?
It was a randomized trial to reduce any bias on one side, and so the results would be statistically significant. Children received either PEDVAX-Hib or Vaxelis along with their other vaccines, and blood draws were done before and after the first dose, as well as after the second and third dose to determine the immune response and compare those so that we could look at non-inferiority of the PRP, which is the antibody against Hib after dose 1.
What regulatory changes resulted from this research, and why is that significant?
The main regulatory change was to evaluate whether the Advisory Committee on Immunization Practice and the Academy of Pediatrics Red Book Committee could change and make a preferential recommendation of Vaxelis for American Indian and Alaska Native children. Before this, I would say most providers in American Indian and Alaska Native facilities treating indigenous children were still using PVAX Hib because they felt they needed to do evidence-based treatment. Many of us wanted to use Vaxelis. There were advantages because it decreased the number of doses by 2 overall, and it decreased the number of doses at the second month, the first dose of vaccines, and the 4-month vaccines, which is really a critical time for infants.
Based on the HibVax study's analysis demonstrating Vaxelis is non-inferior to PVax Hib after the first dose, in June 2024, Vaxelis was included as a preferred vaccine for Alaska Native and American Indian infants, giving parents and clinicians the option to use either formulation. Vaxelis is now available at tribal health facilities across the state of Alaska. What led to your research on the health impacts of Alaska Native women changing from traditional diets to eating more processed foods?
In 2010, a colleague came to me and said, "Roz, we are seeing too many children with rickets." Rickets is severe vitamin D deficiency among young children with growing bones. In young infants, it can lead to seizures from low calcium levels and be life-threatening. It can also have cardiac complications and affect almost every system in the body. In slightly older children, as they start to walk, you see significant bowing of the legs because the bones are so soft that they don't hold weight. We were starting to see cases of flagrant rickets among Alaska Native children back in the 1990s. So we were like, what is going on? We didn't expect that. Research showed that we were seeing cases in very young infants. Over half were less than a year, and 47% were less than 6 months of age. So very young infants. So we proposed that maternal diet had a significant impact. So we increased supplementation among infants, but at the same time, we wanted to investigate what was going on with maternal vitamin D levels in prenatal women. That was very important because our research showed us that back in the 80s and 70s, we saw very few cases of rickets.
The research described in declines in traditional marine food intake and vitamin D levels from the 1960s to present in young Alaska Native women was able to show changes in the diets of Alaska Native young women over time using serum samples from the specimen bank. How were biospecimens collected over decades an important resource for this research?
We were able to obtain de-identified samples from the Alaska Native Specimen Bank, which is housed at the Centers for Disease Control Arctic Investigations Program, and it is overseen by a tribal board. The board that oversees it approves any study that uses those samples. Are samples that are collected over many, many decades and with approval to save samples by the individual. And any use of those samples has to go through the board and the IRB, the Institutional Review Board. So it has to go through the specimen board and then also the Institutional Review Board. We were able to identify samples in childbearing age women in their 20s from Western Alaska with samples as early as 1960s and all the way to the 2000s. And then we did vitamin D levels on those samples. Then we also were able to collaborate with a professor at University of Alaska Fairbanks who did biomarkers for a marine diet, a delta 15N on these samples. So we had a vitamin D level and a biomarker for marine diet on these women in their 20s from the 1960s up to the 2000s. And we saw a dramatic decrease in vitamin D levels as well as marine diet intake of fish, which really complemented what we'd seen with dietary surveys over the years. To give you an example, in the 1970s, 100% of women in the sample were sufficient for vitamin D. And women at that time had an intake of salmon and other fish and marine life that was about the same as elders today, which is very, very high. In rural areas, an individual has about 250 pounds of wild fish and meat every year, compared with about 14 pounds in urban areas. So it's a large part of the diet. But many women were in the workforce. They were busy. They had more of a Western diet over the years. So there was a decrease in vitamin D. And we saw that decrease when we did surveys of women in pregnancy. We saw the same thing in the late 2000s. So we increased vitamin D supplementation in women, and the Alaska Vitamin D Work Group made that recommendation. Initially, in YK Delta, we did an evaluation that showed that 1,000 milligrams of vitamin D in addition to prenatal vitamins was effective in increasing vitamin D levels in late pregnancy in women. So those findings led to a more generalized recommendation. This was a key study in showing that change over time.
Your research was able to demonstrate a significant decline in consumption of traditional marine foods by young Alaska Native women and an associated significant decline in serum vitamin D concentrations. Based on your other research, what are the implications of these changes for the health of Alaska Native women and children?
Well, the biggest implication is that we know that young women right now have much lower vitamin D levels than they did in the past, and that it's related to diet. So there's two things that need to happen immediately. We need to make sure women have adequate vitamin D supplementation to reduce the risk for early rickets, including congenital rickets. That means infants born with rickets. In addition to that, there's a number of initiatives around indigenous diet and traditional foods in YK Delta and around the state. There's a traditional foods work group. There's efforts to increase fish in schools. There's young cooks developing great recipes for people and lots of initiatives around increasing intake of salmon among younger people.
Can you explain the evidence on the relationship between vitamin D levels and dental caries or cavities in children?
Especially in the 2000s, vitamin D was very vogue, and there were lots of allegations and observational studies that showed links between vitamin D levels and cancer and TB and respiratory illness, cardiac status, and on and on. Most of that is from observational studies, and there's very few clinical studies that actually show a effect of that observation. However, there is one other association besides rickets and bone health, and that is dental caries. And it makes sense because vitamin D levels in prenatal women affect ameliogenesis, which is the development of teeth in utero. So it would make sense that vitamin D levels have an impact on teeth over time. And we know, especially with the development of enamel, we know that enamel hypoplasia, that's poor enamel development, leads to caries, leads to dental cavities. So there's good biologic plausibility for vitamin D in pregnancy having an impact on dental caries. And in fact, as early as the 1930s, there have been initiatives to increase vitamin D and sun exposure for the purpose of reducing dental caries. We did not have the ability to do a clinical study, but we did add to the literature on observational study, which showed that women with much lower vitamin D levels during late pregnancy had children who, at a year to 2 years of age, had higher rates of dental caries. So we did show a correlation between very low vitamin D levels in pregnancy and higher rates of dental caries. So that's a potential secondary gain from vitamin D supplementation during pregnancy and increasing vitamin D in the diet. Why do we talk about diet so much for vitamin D in Alaska? Because for the lower 48, the important factor for vitamin D is actually sun exposure. If you live in Tucson, you get almost all of your vitamin D from the sun. However, if you live in Alaska, because of the direction of the UV rays, the gradient, and the time that we have low UV light in the winter, we have very little vitamin D that comes from the sun, probably less than 10%. So most of the vitamin D in our bodies comes from our diet in Alaska. So it's very different from the rest of the population in the United States.
Do you see vitamin D supplementation for Alaska Native women of childbearing age as a sustainable and adequate intervention to compensate for the change in nutrition as people eat less fish?
Yes, if women are educated and take the supplement regularly, With good education, it's not a difficult thing for women to take an extra vitamin D every day, and most women, when they realize the risk, will do that. I think it's also important to recognize the very important contribution of diet. There's many reasons why salmon and other fish are just a great source of nutrition for Alaskans, so we should never forget the importance of diet. But yes, it is adequate to provide an additional supplementation.
Is there anything else you'd like to add related to population level nutrition changes from a One Health perspective?
I will just go back in my unfortunately lengthy career. When I started working on the Navajo reservation in 1985, we had quite a few children with failure to thrive, but I did not treat children with obesity. And at that time, there was still a lot of traditional foods among that population, among Alaska Native, and a very similar thing was true among Alaska Native children. In fact, my colleagues in internal medicine had a very low number of coronary artery disease patients that they treated because people had a very different diet. As diet became more westernized and fast food became much more available, obesity increased by leaps and bounds. In Alaska, one big source was sugared drinks, which became very prominent because water sometimes has less palatability in certain areas of Alaska. And so people used Coke and Gatorade as an alternative. And that has led to a significant rate of dental caries, and that and fast food has led to a significant rate of obesity that is really a new disorder I've seen in my lifetime. We did not experience that in 1985 when I started, and it's due to a change in diet.
Just last week, the President and Secretary of Health and Human Services advised acetaminophen should be avoided in pregnancy because it causes autism. As a doctor who has spent decades researching maternal child health, what would you tell epidemiology students about how causal relationships are established in public health?
There's lots of observational data and small studies that people may cite, but that does not develop causality. There's a process of developing causality that requires both biologic plausibility and large observational studies, as well as randomized studies to evaluate. And this has not met that scrutiny as well as many other recommendations. So it is important to look at the evidence base on any recommendation.
In the same speech, the president called it a disgrace that children are given so many vaccines and advised parents to space them out rather than following the recommended vaccine schedule and to avoid combination vaccines. What are the public health implications if parents follow the president's medical advice?
Well, we've already seen the implications over the last many months that the secretary has been in office, and those have been we've had the highest measles rate in 3 decades. Measles is one infection that you will see very rapidly when vaccination rates drop. Virtually everyone got measles prior to vaccine, and measles leads to hospitalization and severe diarrhea and pneumonia in many cases, and the hidden thing is that measles illness has a dramatic effect on your immune system for at least 2 years. And studies showed that after vaccine, which led to basically an elimination of measles in the United States, that all infectious disease deaths decreased by half. And that is because of the dramatic effect that measles has on our immune system, making us more susceptible to other infections. We had a case in Alaska in 1990 of an infant who developed measles, and then she died of Hib meningitis a week or two later because her immune system was dramatically impacted by measles. Measles is so infectious that you don't even have to be in the same room to get measles. You just have to be in the same air of someone who had measles within 2 hours, and there's many studies showing spread of measles. So that is why if children go to school and are not immune to measles, we will see measles outbreaks, and that's why we have seen measles outbreaks. And we've seen the first deaths from measles in decades because we have no longer eliminated measles, and there's many other vaccine preventable diseases that will start to emerge. In Russia, for instance, after the fall of the USSR, there was a upheaval in the public health system in Russia in the early 1990s, and they had a massive diphtheria outbreak in Russia. None of us ever imagines having diphtheria in the United States. We haven't had diphtheria in many, many decades, but that's yet another disease that will start to emerge if we do not have high vaccination rates. So not only individuals who are not vaccinated will be affected, but everyone will be affected, including infants too young to be protected by vaccines.
What lessons can be learned about best practices for communicating health information to the public from this example?
I think the public needs to understand why vaccines are important, what they are protecting us against, and they need to have clear evidence of the benefits of vaccination and individual vaccines. They need to understand why children are vaccinated. That's an imminent requirement, and it's been an issue since Benjamin Franklin. Benjamin Franklin did not have his child vaccinated against smallpox. Inoculation against smallpox was available then, but he was afraid of the risks, which then were much, much higher than they now are. There's very, very low risk. I personally have seen no serious complications from vaccines in my career from children who are vaccinated. There are very rare risks, but they're very rare. So he did not vaccinate his child who died of smallpox. And he talked later about his regret. And he talked about the balance of risk and that he regretted that he had not vaccinated his child because the risk of the one was so much lower than the risk of smallpox itself. Smallpox is the only vaccine preventable disease that has been eradicated. Measles was eliminated in the Western Hemisphere, and polio is very close to eradication. But if we stop now and don't continue to vaccinate, then we will start to see these deadly infections come back, including potentially polio and Hib meningitis, which would just make me ache, my soul ache for all the needless death that would occur.
During that speech, the president claimed that hepatitis B virus is only sexually transmitted, so he advised Americans to wait until age 12 to get the vaccine. What do you anticipate would happen in villages in the Yukon-Kuskokwim Delta and Norton Sound if babies are no longer vaccinated against hepatitis B per the president's medical advice?
Prior to vaccine, rates of hepatitis B in Western Alaska were 250 per 100,000 as compared to zero point 0.5 per 100,000 in the US. And even within the last few years, there were 1,500 hepatitis B carriers among Alaska Native women. And in my early career, we had teenagers who died of hepatitis B that they acquired as infants. If you acquire hepatitis B as an infant, you have a 90% chance of developing chronic hepatitis B. Hepatitis B is 100 times more infectious than HIV. You don't need sexual contact for hepatitis B. You could share the same toothbrush. You could share the same razor. You could be a wrestler and have an open wound that someone else goes on the same mat, and you could get hepatitis B from that contact. It is bloodborne infections that's highly transmissible. And the earliest and best way to prevent hepatitis B is as a newborn. And then that newborn has protection that lasts. And many, many studies has shown lasting protection and almost a complete control of hepatitis B among Alaska Native people. If we were no longer going to vaccinate children, we would start to see children again with hepatitis B and the chronic results, which are cirrhosis and liver cancer.
What advice do you have for epidemiology and other One Health students?
Be vigilant. What you do in life matters. The decisions that you make affect not only you, but your community. And it's important to live a life that is based on the evidence and not hearsay. Thank you.
Roz, thank you so much for joining me this morning to talk to One Health epidemiology students.